Okay, I think we'll switch then now to Dr. Vicki Kristmann. Vicki, are you ready to share?
Sure am.
Great, thanks. And she's presenting about the Northern Ontario. Sorry, I switched my screen, so I don't have the title right there. It's a Northwestern Ontario Workplace and Worker Health Cohort Study, which we'll put the link in the chat, and she's going to tell us what's happening with it and who can participate, and also potentially about their other work at Lakehead in the EPID Work Institute. And I'll just introduce her bio and thank you for joining us. Dr. Vicki Kristmann is a professor in the Department of Health Sciences and director and senior scientist of the EPID Work Research Institute at Lakehead University in Thunder Bay. She holds a Lakehead University Ontario Research Chair in Injury and Disability Prevention. She conducts research to better understand factors associated with health, particularly mental health and disability in the workplace, to develop and test interventions to improve the lives of workers. So over to you, Vicki, to talk about what's happening with the Northwestern Ontario Workplace and Worker Health Study. Thanks.
Great. Thank you so much, Val, and thank you for allowing me or giving me the opportunity to present this work to you. So this is an ongoing study. So I'm going to give you a little bit of background about why we started to take on this work, and then going to give you just very preliminary some findings that we have from the baseline piece. So this is an ongoing cohort study that we hope will be going on for quite some time. So there is an opportunity to participate, and we highly encourage any worker that is working in Northwestern Ontario to please get involved. And I'll explain a little bit how to do that as we proceed. So just to give you a little bit of background, so mental health has been a challenge in Northwestern Ontario for some time. Actually, when I first came to Thunder Bay and Lakehead University, I was approached by a worker from the WSPS who came to my office. Actually, at the time, I had just been doing some work at the Institute for Work and Health, and in one of their lay publications, some of my stuff was published there. And this person saw that I was actually at Lakehead now, so actually came to my office and said, "Hey, this is great work, but it's all on musculoskeletal issues. We really need you to focus on workplace mental health here." So I said, "Okay, let's write a grant and do some work." So we did that. We had a grant funded through the Manitoba Workers' Compensation Board to look at some issues around accommodation for mental health in the workplace. But anecdotally, this issue has been in Northwestern Ontario for some time. A survey that we gave to employers through the Thunder Bay District Health Unit just in the last year indicated that 62% of employers are rating their employee mental health as either fair or poor. So this is it seems like it's a problem, but we don't actually have a good handle on the actual annual prevalence. So how many people at any one time are suffering from a mental health disorder in their workplace, and the incidents, how many new incidents or events of mental health are we seeing each year in Northwestern Ontario. So this is something that we want to establish. We also have within Canada our Canadian National Standard, so the Psychological Health and Safety in the Workplace Standard, to actually help workplaces to prevent and promote mental health in the workplace. Our same survey that we conducted, we asked about knowledge about the standard in the last year, and 34% of employers were not even at all familiar with it. Only 8% who were familiar with it actually had a plan in place to try to implement it, and the rest of them didn't even have a plan in place. And I think one of the challenges with this as a standard, it's a little daunting. It's quite large. It comes with an implementation guide and an online toolkit to support its implementation. So I think for a lot of employers, particularly a number of smaller employers, which we do have a lot of in Northwestern Ontario, it tends to just be too much of a burden, something that they can't take on the entire thing. And I think this is one of the challenges and why it's not being actually implemented, if they're even aware of it. But within the standard, there are 13 factors, and these are the factors that have been recognized as important psychological health and safety workplace factors. As you can see from what's posted here, a lot of it is there's a lot of overlap among these. And what we want to try to determine is for those employers who are smaller, or even for large employers that you might have limited resources that you can spend on this area. We want to find out what is the one or two things that a workplace can actually do that will enhance and get them the biggest bang for their buck in the area of psychological health and safety. So there is currently an instrument that's recommended with the standard called the Guarding Minds at Work questionnaire, and I know even among the group that I work with at the Superior Mental Wellness at Work group, that's the Thunder Bay District Health Unit, this instrument is still being promoted and suggested, but some work from actually the Institute for Work and Health and OCAL with Smith and Udek actually found that this instrument really isn't that great. It had a lot of challenges in terms of ceiling effects. A confirmatory factor analysis model found that the conceptual model that was actually to link the 13 factors to the 65 items in that survey, not great. A lot of correlation between the dimensions, poor discrimination in measuring those factors. So overall, they said, you know what, using this instrument is just not going to be able to identify the dimensions of the work environment that you really need to focus on. So that's another gap that we need to try to fill in what we're trying to do with our work. Some other things that we have in terms of just the overall evidence on workplace mental health. The national standard is primarily based on research that was done in a cross-sectional surveys. So it's really one point in time, they measure the risk factors in the workplace, but they also measure mental health status. Well, the challenge with that is that those who are struggling with their mental health may report the workplace a little bit differently because they're actually experiencing a mental health challenge right at that moment. So cross-sectional evidence doesn't really provide great evidence for a causal mechanism to help us understand what is leading to mental health challenges in the workplace. And for the studies that do have longitudinal evidence, a lot of this is from secondary data analysis. So they've used existing data sources. And again, there's also a lot of risks of bias here. There can be uncontrolled confounding because certain things weren't measured in the data that they used. The way people are selected into the study can lead to selection bias. Challenges with how exposures are measured and the mental health outcomes are measured, and overall missing data. So I think there's some really big challenges that we are experiencing in this longitudinal evidence that we currently have. And I think there's a huge gap here where we do need some high quality evidence. And that's exactly what we want to try to do. So the objective of our study, which we're calling the NOWWHS, is to, as I said, determine the prevalence and incidence of mental well-being and mental disorders in Northwestern Ontario workplaces, determine what the workplace and worker risk factors are that are associated with mental well-being and mental disorders in Northwestern Ontario workplaces. This includes those validated measures that we have for the 13 factors in the standard. And we also want to do this in a cohort design so that we know for sure that those exposures are occurring before the development of the mental health disorder. And finally, we really do see this as a community research tool for all of Northwestern Ontario. We want to develop a prospective cohort for surveillance so that over time we can see what is impacting the levels of mental health in organizations. We can use it as a prognostic factor for prognostic factor identification, again, to determine what are the factors that actually are causing or leading to some of these challenges. And then finally, intervention assessment. I think this is one of the gaps that I think even from Emil and Emma's study really showed that we don't have a lot of great interventions for workplaces themselves. A lot of it falls back onto workers to become more resilient, to learn better coping strategies. But maybe if we actually help workplaces to improve the workplace itself, workers can just be themselves and not have to go through all of those things to try to make themselves be resilient for a workplace that's just putting too much on them. So really that's the overall goal we're trying to do, and we're trying to evaluate existing interventions and then also develop new ones from when we find gaps where there isn't anything right now that workplaces can avail themselves of. So when I say Northwestern Ontario, this is the area that we're referring to. So we're literally looking from Hudson Bay in the north, in James Bay, all the way to the south to Lake Superior and the US border, in the west, Manitoba, and then in the east to the town of Manitouwadge. And when I say prospective cohort study, well, what do I mean by that? Basically, what we do is we look at a population of individuals, and then we determine whether or not they're exposed to something. So for example, if I wanted to use workplace bullying as an example, we can ask participants or determine whether or not they've been exposed to workplace bullying in their workplace. They would get put in the exposed group. Those who have not had that exposure would go in the non-exposed group. And then we follow them over a period of time to look at the outcomes. So if we want to look at depression, for example, and then we can see, oh, sorry, I don't know if people heard that. You can see the little lightning bolts in those people. Those are people who have actually developed the outcome. So for example, depression, you'll see there's 4 out of the 6 in those who are exposed that have developed depression, and only 2 out of the 6 that were not exposed. So it gives us an idea. It allows us to understand what exposures are leading to increased amounts of particular outcomes. And this particular study design has been used in some very famous studies, including the Framingham Heart and Health Study. This was a prospective cohort study of about 5,200 residents in the town of Framingham, and really has helped us to understand more about cardiovascular disease than any other study. And it continues on today. They're now studying, I think, the great-grandchildren of the original participants. And we're really hoping that our study can have the similar impact as the Framingham Heart and Health Study did for cardiovascular disease, as our study will do for mental health in the workplace. So our study looks like this. So we are collecting data from both workplaces and workers. So basically at baseline, individual workers can participate, and there's 3 ways to participate in this study, which I'll tell you in a minute. But basically, once people participate, for workers, we ask them to complete a survey every 6 months. That's so we can understand their baseline situation. And then obviously the follow-up surveys are shorter because things that haven't changed, we don't ask again. And then for the workplace, we come to the workplace for participating workplaces, conduct the survey with them, and then do a follow-up survey 1 year later. So how people can get recruited into this study, as I said, there's 3 ways. So first of all, employers can come to our website, workinghealth.ca, click on that sign up button there, and that will trigger an email to our research institute, where our project coordinators will reach out to you and arrange a time when we figure out a mechanism where we can come to the workplace. Obviously, for larger workplaces, sometimes it takes more than 1 or 2 visits, but we want to try to meet with all of the workers if possible to try to encourage them to participate in the study. Individual workers can actually come also to this website. So say, for example, their employer may not be interested in participating in this study. They themselves can participate. They can click on the link here to either sign up for later, which will trigger an email if they don't have time to do it right at that moment. And that will come to them, and then they can follow the link in that email to do it at a more convenient time. Or they can click on the link right here where it says take the survey now and actually complete it right at that moment. And I'll take you to an informed consent letter, which tells you a little bit more about the study and then leads into the survey itself. One additional way that we are actually also doing random selection. So we have a list of over 6,000 businesses that we've built by using a company that provides business information, and also from the WSIB, who's provided some information to help us randomly select employers just to reach out to try to encourage a broad selection of employers to participate in this study. Here's what we're trying to do is collect 300 workers from each of 20 industrial sectors, so to get a total of 6,000 workers. So again, very comparable to the number that were in the Framingham Heart and Health Study. Again, we want to follow workers up every 6 months and top up these samples, each sample wave, with an additional 50 workers from each sector, just to ensure things happen. We do get lost to follow up. We want to make sure that we have a stable sample over time. We currently have just posted our dashboard on our workinghealth.ca website, which shows the real-time data collection. So it shows you how many people have participated in the study, what groups. So for example, I'll show you some of the groups we're really focusing on in the study and how many numbers we're getting in those areas as well. And as we develop more findings from the study, we will be posting those there as well. So it's a place that people, participants or anybody can go and check in and see what we are learning from this study. In terms of eligibility, any workplace that's located in Northwestern Ontario who has at least one employee is eligible to participate. We wanted to make sure, because a lot of epidemiological studies tend to restrict to larger employers just because it doesn't cost as much. If you make one visit, you get more participants than you do from smaller workplaces. But this has actually led to, in the literature, us really knowing very little about those small and medium-sized enterprises. So I think this is something that we want to try to fill that gap. So we are encouraging our smaller employers in Northwestern Ontario to participate in this study, because that's also, Northwestern Ontario has a lot of smaller employers. So I think it's really, really important that we don't exclude those. In terms of workers, as long as a worker has worked in Northwestern Ontario at any point in the past year, aged 14 or older, or we're also including workers who wanted to work in the past year but were unable to do so because they had experienced a workplace injury or a health event. They are also, we have a specific section on injured workers who are eligible to participate as well. Self-employed workers are eligible to participate as a worker, but not as a workplace, given they don't have any, if they don't have any employees. So these are the 20 industrial sectors. This was our original plan. You'll see I've crossed one off, and that's because we actually we had to look at the census data to make sure that there was going to be enough employers in Northwestern Ontario. And unfortunately, management of companies and enterprises, from the last census, there were actually 0 companies in Northwestern Ontario working in that sector. So I can guarantee we will not get enough numbers in that sector to be able to speak to that one. But the others, I think, for some cases, we're going to have to have quite a high success rate in order to hit the number 300. But for others, it should not be a problem. For example, healthcare and social assistance, education, all of those sectors, we tend to have quite high numbers in Northwestern Ontario. So I think for the other sectors, we should be able to reach our target. In terms of what information we're collecting, we want to understand what people are doing in their job. So what is your job, your work schedule, work time, exposure to hazards, physical hazards primarily, because we do ask a lot about the psychosocial things in the workplace factors section. Also job intention, do you intend to stay? We ask about mental and physical health. So we have specific validated instruments that we're using for each of these: mental well-being, anxiety, burnout, depression, activity limitations, other health problems, health comorbidities, we're also capturing that. Workplace factors, again, we're looking at particularly the 13 factors identified in the standard, but we've also included stigma and injustice as well. And in terms of personal factors, we understand that mental health doesn't occur in isolation. It doesn't just happen at your workplace and you can leave it there. Things from home come to work, things from work go home. So we want to really try to understand how people perceive their stress levels. What is their coping strategy, social support, all of these things. So we can use these things as control mechanisms more than anything to ensure that it is actually we can really highlight and pinpoint what it is that's happening at the workplace. That will actually help us understand where we should be targeting interventions. And then finally, personal demographics, date of birth, sex, education, the typical. But this is really important because this is actually going to allow us, with the sample size that we've proposed, we should start to be able to look at some intersectionality things. As Steve mentioned, that intersectionality is really important because there are particular groups within the population who do experience other issues in terms of potential discrimination, things like that, that make it more challenging for them. And we should be able to, with the sample size proposed, actually look at some of these intersectionality challenges. And these are some of the additional groups that we have identified. Now, these groups have been identified primarily, we did a very large consultation exercise before rolling out this study to get a sense of what our stakeholders in Northwestern Ontario felt were really important. So these are areas that we are, basically we call them kickouts. They're, if you indicate that, for example, you're a nurse, there's a little extra section of questions that you will complete. And Ainsley Miller, a PhD student, is actually leading that section. We also have a PhD student, Kara Polson, looking at those who work from home and what their mental health challenges are. Josiane Bunting is a master's student, Master of Health Sciences. She's looking at Indigenous workers. and Ume Kabir is also a PhD student looking at immigrant workers. But we're also including information on older workers, supervisors, particularly in mining sector, paramedics, and injured workers as well. So I just wanted to give you a really brief highlight of our some preliminary findings. So this is including about almost 700 participants. And basically, I just wanted to show you what the prevalence of the mental health outcomes are that we're seeing so far, and do this by looking at how they participated, either through their workplace or by just signing up online themselves, and then just look at some bivariable associations. And I can only do this again, is not really adding a whole pile to the literature because it's still cross-sectional. We don't have enough follow-up information yet to actually look at the longitudinal cohort piece. But just to give you a sense of who's participating, so far 36% of our participants are in the healthcare and social assistance sectors. Roughly 10% in education, and 8% in other services, and another 8% in professional, scientific, and technical services. Our participants at this point are primarily female. We have 66% female. But again, I think that's a representation of the sectors that have participated to date. Mean age is around 40, mostly college or university graduates, about 70%. 45% married, 26% never married, and 18% common law. And the majority of the participants have been working in Thunder Bay, 63%, 27% in smaller cities and towns, 4% in rural areas, and 4% working on reserve. In terms of the prevalence of mental health outcomes, this is just showing, we're looking at depression, anxiety, post-traumatic stress disorder, and low mental well-being. That's as measured by the Warwick-Edinburgh Mental Wellbeing Scale. You can see here that the prevalence levels are fairly high. For example, in the online participants, particularly, almost half are reporting depression. That's not incredibly surprising, because if you think about who is going to actually go online, click the link to actually do it, it's going to likely be somebody who is suffering from, as you can see, depression or anxiety, 28% post-traumatic stress disorder, and 25% of the online participants also reporting low mental well-being. Those estimates are quite a bit lower in the workplace, which we would also expect, because we are going to workplaces and we're just getting a sample of individuals, not necessarily that are struggling with any particular mental health or health event. But you can see here that we're still seeing fairly high levels of depression, 26% of depression, 31% anxiety, 13% PTSD, and 15% reporting low mental well-being. So definitely there are some significant challenges ongoing in terms of the prevalence of mental health. When we look at some of the factors and we look at their association with mental well-being, so this is looking at some of the continuous factors. So these factors are measured continuously. So we have organizational culture using the organizational cultural profile instrument. We've also got instruments for leadership, incivility, engagement, growth, and development. This is just a selection. We have many more, but this is just a selection. And this showing all of these were highly associated with mental well-being. So you can see those reporting high mental well-being were 7.5. There's a difference of 7.5 on the organizational culture scale between those reporting high and low mental well-being. So statistically significant. At this point, only stigma has not been statistically significantly associated with mental well-being. Not particularly surprising either, because stigma actually asks about the individuals. It's the OMSWA questionnaire and asks about if you hold stigmatizing attitudes. So I wouldn't expect that somebody holding mental health stigmatizing attitudes is going to actually be struggling from a mental challenge. And you can see here that we have so far found that that's the case. And then in terms of the workplace factors and mental well-being, this is some of the categorical factors. So this just showing workplace expectations. So do they get clear expectations from their supervisor? So those reporting high mental well-being were 6 times more likely to receive clear expectations, or very frequently are always likely to receive clear expectations compared to those with low mental well-being. And you can see that between 5.5 and 6.5 is pretty much if once you hit occasionally all the way to always frequently, we see that there's an increased likelihood of it being in the higher mental well-being group. In terms of role conflict, so this is free from conflicting demands, we find that those reporting high mental well-being were 13 times more likely to report always being free from conflicting demands in their workplace. So, and you can see here that this actually increases as you go from sometimes to always, tends to have an increasing likelihood of placing people in the high mental well-being group. Some of the other factors, so we haven't found an association yet with experiencing violence, but those with high mental well-being were 50% less likely to say that they'd experienced being bullied. Those with high mental well-being were 60% less likely to have experienced sexual harassment and 70% less likely to have experienced discrimination. So all of these have so far, with the data that we've collected, are showing a statistically significant cross-sectional association. And again, I think it's really important to highlight that these are just cross-sectional associations. It's a very preliminary analysis on fairly small numbers. We're looking at under 1,000 here, but it is primarily from 2 or 3 sectors. We still have a long way to go in terms of collecting data from all of the other sectors that were of interest. And again, there's no control for any confounding factors here. There might be other factors that are contributing, that are actually explaining those associations that we're seeing here, but we haven't included any control for confounding in this particular preliminary analysis. So basically, stay tuned. We will be doing all of that. We just need to collect more data and also start getting going on the follow-up surveys. So again, now is the time. I think Northwestern Ontario has shown us that there are high rates of workplace injury, disease, and mental health disorders that I do think really support the study of like this here in the North. We have a diversity of workplaces, worker populations, and now we have a dedicated research institute, the EPID Work Research Institute, which can really focus on this challenge for the region. And I think our evidence, as I said, is related to mental health is mostly cross-sectional and it varies in quality. So this is a huge gap that I think we really can fill here. And this study also does provide a platform where we can conduct fairly rapid evaluation of both planned and unplanned interventions. So we may incorporate an intervention into a particular workplace, and then we'll be able to evaluate it by continuing to do our follow-ups with the workers, but also things that we don't plan that might happen. Heaven forbid we ever have another pandemic, but we would have this data in place so that we could capture and see the effect that would actually happen in workplaces and on workers. So again, just in closing, it does take a village to this. This is just the people who have been listed on our REB applications. There's many, many more who have contributed to this study. It does take to do a study of this magnitude takes a lot of help and collaborations, and we've definitely been working to do that, and we'll continue to do so. So if there's something that you've seen in the presentation today that you think maybe we're missing, we would love to hear from you, because we'd love to hear what thoughts and what people think are really important. I'd also like to acknowledge the funder of the EPID Work Research Institute, the Ministry of Labor, Immigration, Training, and Skills Development, for funding the Institute, which is in turn funding this particular study at this point. We have applied for other funds, but as I said, this is an expensive endeavor, but we do think it's really important, and we want to make sure that this happens. And again, just to remind everybody what our ultimate goal is really to turn workers who might be looking like this by the end of the day to workers who look like this, who are happy, smiling faces. So again, thank you for your attention, and I'm happy to entertain any questions.
Sorry, my mouse doesn't seem to be working. Thanks a lot, Vicki, and for going through it so quickly, but still giving us a really good sense of sort of the background and then all that you're hoping to achieve, and then even some of the preliminary results, which is quite interesting and alarming. But I realize there's some bias to who goes and will take the time to complete the survey. Tanya Muller just asked a question about the figures for reported depression or anxiety being a clinical diagnosis or self-reported. I think you mentioned the tool that you were using for the questionnaire. Edinburgh.
Yeah, yeah, that's for Edinburgh was for the mental well-being. We are using the PHQ for depression and the GAD-7 for anxiety. So these are tools and validated instruments, but they are being used in a self-reported. We don't have a clinician actually administering those to the individuals because they can go online and complete it themselves. But they are tools that have been validated in the population to be fairly accurate in terms of I wouldn't say diagnosing, but identifying, helping to identify. In particular, for depression, it's not necessarily depression per se, but it's depressive symptomatology.
Mm-hmm. So Andrea asks about recommendations for an alternative to guarding minds. Of course, I have a bias there in terms of our product Stress Assess, but maybe you'd like to comment on any others. And we actually are, as I put in the chat, John's talking about validation of surveys and why it matters, and then other factors that matter in a survey in a workplace next week, and some other tools by PSHSA and WSPS will be shared at the next 2 weeks. But I don't know, I'll let you answer as well. I just wanted to.
Yeah, no, that's one of the things that we're hoping to do with this study is actually identify what are the most important things that employers could measure and then address to help them improve their psychological health and safety in the workplace. So I think I don't have recommendations at this point, but I'm hoping as we learn more from the study that that's one of our intended goals is actually to see what should employers be focusing their measures on so that they can then include interventions that would address those specific things if it is a challenge for them. And I should say through this study, what we are doing is for employers who participate, we do give them a report after every 6 months. We're trying to do it within 6 months of them completing one of the follow-ups, and that's so that we can help them identify. And we have a meeting tomorrow with our health and safety associations and other important stakeholders, including OCAL, to help us see what recommendations can we make for employers that have already, there's interventions that already exist based on the data that we learned from the survey and their workforce. What can they do? What can they avail themselves of to actually help out? So that is part of and this often workplaces will pay thousands of dollars to get this. We're offering it for free just for participating in our study. So we really do want people to get engaged and help us to learn more so that we can help make better guidance and make sure that the right intervention is getting offered at the right time to the right place.
That's great. And yeah, Stacy does comment on the energetic presentation and the work. So thanks for that. Any other questions about other parts of Ontario? I was actually going to, the comparison, or is there a way to compare the Northwestern versus elsewhere? We do have data that we presented last year from, we do a standardized every 3 years version of Stress Assess with a panel with ECOS research. So we have that data of the questions that we have in Stress Assess, which includes COPSOC and other questions, but it wouldn't necessarily be directly comparable to the array of questions you're using. But I don't know if there are other data sets that you would be able to use as comparables.
Possibly. We have talked a little bit with Institute for Work and Health about potentially expanding this. I don't think this is something that our research institute can do on its own. We definitely cannot keep the protocol exactly the same. We don't have the mechanisms or the funding to actually travel all across the province to all different employers. But we do have some employers that are participating in this study that have multiple locations. So they have workers in Northwestern Ontario and also in other parts of Ontario. And they have asked if we can include everyone. And we have allowed that. It just means that we won't travel to, for example, Toronto, but we can send a link and people can do the survey. And then when we just want to report on our Northwestern Ontario, we can exclude those pieces, but that way we can give them an overall report of their whole workforce. So there may be opportunities in the future that we can expand it just as a full study, but just doing linkages where we don't actually go to the workplace. We do find when we do attend workplaces, we do get better data, we get better completion rates, and the data tends to be more fuller, complete. So I think that's definitely a challenge. When you just send somebody a link, it's very easy to ignore it and delete it. Where we actually go to workplaces, it's a little bit harder to ignore us. So I think that's one of the challenges is just in terms of the mechanism of the study itself.
Mm-hmm. I was going to actually ask you that related to the difference between the online results being more dramatic than the those collected at the workplace. I assume that the workplace ones are mediated as such in terms of that someone's taking the answers down. So it's not just someone answering honestly by themselves on their own computer. It's somebody where other people can hear the answers, or is
No,
it still?
no, it's still very much confidential. So
Okay.
we do have, since we have people there, they can actually have um, our research associates or research assistants will actually they can take individuals through the survey if they like. What
Mhm.
we're finding is people just prefer just to do it themselves. So we have a bank of tablets, and people
Okay.
will go, and then if they have any questions, they can ask of that. But the way the data is being collected is really not that much different. I think what is different is the impetus for participating. So
Right.
those who are signing up themselves and they're learning about the study, and they often have a challenge. So they're going and they're wanting to sign up so they can talk about the challenge and share their experiences. Where when we go into workplaces, we're getting more of a broad sample of the workplace itself and
Mm-hmm.
not necessarily people who are just struggling with mental health challenges. So I think that's why you're seeing the differences between those two groups.
Okay, good. That's I hadn't understood the difference, so that makes sense. And this deploying tablets in a is something I'm interested in too. We don't necessarily have the time to cover it now, but it's something we've considered doing with other worker groups, even in other languages potentially. I don't know. I assume your whole thing's only in English right now. Is it also French or
It
any
is
other
just in
languages?
English right now. We have talked about that, especially with because we're trying to get a large immigrant population to participate as well, which can also be a challenge. So we are trying to think about, and even if we had somebody present that spoke the language of that individual to just help navigate through the survey, I think would be helpful. So we're still sort of struggling with that a little bit in terms of how to actually make sure that we all people can participate regardless of their level of English. But at this point right now, it is just offered in the English language.
Yeah. Thanks. Yeah, I was thinking that about the predominance in healthcare and social services, getting people who are very comfortable in this environment. It's easier for them to respond because it's a natural fit essentially. But yeah, it'll be a struggle to get workers who are more distanced from technology and from interfacing with things. So that's the challenge of all this work. And I guess we already are running late and losing people. But I did want to thank you, Vicki, and thank Emil and Steve for their participation today. And I wondered if there were any final comments or one of the things I was thinking around even sort of funding, research opportunities, just research in general, and the application of research then to how do we take what we've learned in these three studies that we're talking about? How do we translate that into knowledge and mobilization and all that? I don't know if that's a big long question actually, but if you just wanted to offer any comments on that, sorry, and then I will stop. But I was also interested that you've had a grant, I think, from Manitoba, or was it Steve? And then Emil's is actually from Alberta. And you're funded by Ontario. All our organizations we're Ontario based, but are there sufficient opportunities, research funding opportunities on this important subject or on these important subjects available in Ontario is another question. So I don't know if you want to start, Vicki, because you're on
Sure.
screen already, and then we can go
Yep.
to Emil and Steve.
Yep. I'll first start with your first point about knowledge translation and the implementation piece. So yeah, we actually we have a knowledge mobilization and implementation scientist at the EPID Work Research Institute, Dr. Meryl Lee Nugent, and she's actually building a study from when we give our reports back to the employers. She's got a survey that she wants to send with those reports to get an understanding of how employers intend to use the information that we've provided. And if they do want to continue to work with us, we're actually trying to build a partnership here with participating employers so that we can partner with them to try to find ways with them to address some of the challenges. So we have that piece to try to understand what they intend to do with it, if they want to continue to work with us, so that we can try to build from that and work with them to have an impact. So that's one thing that we're trying to do from that. And Marilee is actually building a whole strategy for how we, as an institute, can try to have an impact in Northwestern Ontario in terms of not just mental health, but just overall workplace health and safety. And then with your second question about the funding, that is always a challenge. I think what we do need to do as scientists, the more we write and publish, and then I think the pandemic itself has also done that, has highlighted how important workplace health, in particular mental health, is. And I think as our policymakers see that this is a challenge for our population, we do see more funding opportunities often arise. So we have applied to our federal funders to see if they will, in terms of trying to support the study further. But I think as researchers, we just need to keep making it clear that this is really important areas. I think society also is helping us to do that by pointing out the challenges involved with this workplace mental health. And I think there's not a lot we can do except for do that and try to encourage to try to promote funding. I know there's the challenge is that there's a lot of other competing health events for example, CIHR, for example, but I think it's really important that we design research that is very rigorous, that will answer the questions, and then we compete the best we can to try to continue to get funds to support this work.
Great, thanks. So Steve, did you want to comment on any last comments around just in general and around these subjects of knowledge mobilization, as well as access to funding or influencing the access to funding or any of that?
Sure. Maybe just to reiterate what was just said, what Vicki just commented on. But I think for one, that when it comes to the topic of work-related suicide, it's just having these discussions is important. I think it's something that we maybe have one-off conversations or hallway conversations, but I think I see this research as filling a role in creating a venue for these different voices to come together. And I think that's important to continue. Getting funding is difficult. It was difficult for me to get funding through SSHRC funding is difficult to get, period, but it's difficult to get on topics that aren't necessarily front and center. But I also think it's just important to support workers and giving workers a voice. Because workers know their situations, workers understand what the issues are, but yet when it comes to addressing any issue in relation to work health and safety, but particularly when it comes to work-related suicide, that workers' voices tend to be marginalized. So I think we can continue to push on that front.
Great, thank you, and thank you for your work. Emil, did you have anything you wanted to add?
Yeah, probably similar to what the last two have said. I would just say that the funding is really important with this kind of work, as has been mentioned. And in our own work, the first responder organization that we spoke to said that they really valued the knowledge that informed best practices, and they felt that was really critical for them to make evidence-informed decisions on the best way forward. So we got it from the people actually working the field, the value of having research done in this space. Our funding was from Alberta, but it's broadly applicable. So certainly it's the kind of work that jurisdictions across Canada should be supporting, whether it's at the provincial level or at the federal level as well, because this knowledge is really critical to helping inform, the best way forward. And it's probably at the end of the day, a savings for organizations to have that knowledge base helping from the decision making, because a lot of trial and error happened in the past, and they've tried different programs, invested quite a bit of resources, and then it didn't work well, and so they're shopping around for other options, kind of thing. So I think that the research really helps support making effective decisions in the field. Funding for us, we're doing several projects in this space. So we have a couple of pockets of funding from Alberta, one from Ontario that we're looking at the police force and PTSI amongst police officers. So it's come from various places. And our knowledge mobilization efforts are multi-layered. I mean, some of it goes into peer review, but most importantly, we're trying to develop tools and resources from this knowledge base that can be used in the field. So best practice guidance for first responder organizations. So that's what we're currently working on with the bucket of funding that we have from Alberta to take this to the next step of developing some tools and resources for policy decision makers in the field.
Great, thanks. Yeah, I was thinking about that in terms of you all shared partial research or early findings, and of course you want. My temptation would be to like, okay, let's make a bunch of tools that reflect that it can vary. But then, are you influencing things in the process, or do you wait until it's all the statistical analysis has been done so you can say it's bona fide, validated, verified, or do you start saying, well, we see some themes, we see some patterns, and that's enough to at least, communicate
Yes,
about that.
yeah. Good point. The way we work is often done in parallel. Stakeholders are involved as partners from the get-go, and a lot of the messaging works in conjunction with their efforts to help us interpret what we're hearing in the field when we do key informed interviews, or when we're doing syntheses of literatures, translating that into kind of key messages for people in the field is part of that process that's done in parallel, so that by the time the study's done, even before it's published, we'll already have a good handle on the kind of guidance we're trying to take out to the constituency who are interested in these issues.
Great, thanks. I guess it's an iterative process. And
yeah.
So
exactly.
we probably should call a halt. We're already almost a half an hour over, and obviously some of us could talk about this all day. But I do really appreciate the four speakers who were here: Emma, Emile, Steve, and Vicki. And I appreciate everybody who attended, as well as the ones who stayed and are still listening. And as I mentioned in the chat, we will post the videos. Like it's on our YouTube channel now. It will render right away as a video, but we'll also divide it up by the subject, and we'll share the slides with that posting probably early next week. And we do have 2 more sessions in the series next week. We're talking about some key issues around workplace mental health, including chronic pain and the link to opioid, and recognizing that link in terms of harm reduction or prevention, and also about workplace violence risk assessment. And then John Audick, who is our survey expert on the COP/SUC and Stress Assess, is presenting on why validation matters, and sort of the difference that it makes, but also on other factors that affect survey success and workplace surveys, where they're trying to solve things themselves. And then the final week is some new tools. PSHSA has a new workplace mental health toolkit that includes a survey, but it's mostly about worker engagement of the workplace parties in joint problem solving and that kind of thing. And then they also have a workplace violence one. And then we're presenting about Job Assess, which is our new job demands analysis tool that's online, that includes psychosocial factors, cognitive and emotional, environmental, things like that. So I hope to see everybody in the next 2 weeks, and then those will all be online as well. So we'll say goodbye now, I think. I'm not sure. I just want to make sure I haven't missed Ken's comment about snakes and ladders. I guess there's going up and coming down, and hopefully learning and going back up again. So thanks again to everybody for their participation, and have a good day and enjoy a healthy and safe and hopefully recreationally rewarding long weekend, which we're already looking forward to, right? So bye.
Thanks so much. Bye-bye.
Thank you. Bye now.